particular talk that starts and talks about children are just small adults, right? Of course, every medical talk has to talk that way, but no, they're not, and that's why we do this. It's a pretty meaty, we'll be whipping through it kind of quickly, so look at these slides later for those of you in the field so that you know what you're looking for and what are kind of unique to children themselves. Very important, obviously, topic because as kids get more and more involved in sports, and specifically as kids get more and more involved in one sport all year round, we are seeing more and more chronic conditions or chronic injuries that used to exist only in the older population and happening more and more often in the younger population, in addition to the fact that kids are getting hurt younger and younger. There are certain stages, obviously, children and adolescents, and we tend to define them as up to when the growth plate closes, which certainly can be 16 or above for most people. The average age, like I said, is early teens, but it does get younger and younger. Not only collision sports, but also most contact sports are the ones that are involved. Why is the child not just a small adult? Well, each child obviously is growing, but each child grows at a different rate for different body parts, such that the torso or the arms may grow before the legs, and they do not grow symmetrically top and bottom. Also, if you have a group or a soccer team that is an 11 and under or 11-year-old group, an 11-year-old boy who is born in January probably is a little less mature than someone who was born later than that. So, but they're playing on the same team, and there could be a huge number of discrepancies between the physical characteristics associated with each child. Of course, growth spurts are very important to think about. In our clinics, as family medicine physicians especially, we get so lucky because we get to see everybody from birth until death, or cradled until death, so we have to be kind of aware of all of these particular topics, is that one of the questions to always ask a child or their parents is, has he had she had a recent growth spurt? And then that will help delineate what your working differential diagnoses are. And of course, in the young skeleton, we have more associated cartilage and bone than the actual ligament itself, because the injuries to the cartilage and the bones themselves are a little softer. All right, we're going to go by region. We're going to go by the most common ones, and then hopefully a little bit of what they present as and how they are treated. So impingement is usually internal impingement in the child itself, associated with a capsule and a deficit in internal or external rotation. You're going to see a swimmer all the time. That's like the bane of our existence, right? In sports medicine, swimmer comes in with shoulder pain. You want to go hide off in the break room or over in your nursing station. And they use their shoulders all the time. So, of course, there's a lot of talking about how to go combat it. It's really a management issue for swimmers, but not overhead athletes, because they have more likelihood of an acute injury. Multidirectional instability back in the day, multiple subluxations or dislocations, or even just overall general laxity was treated surgically, but we now know that's not the preferred option, and physical therapy is always the option for some multidirectional instability. Little leaguer shoulder is just the inflammation of the proximal growth plate or the epiphysis of the humerus. It is something that we see quite often, and it's almost like I prejudge my patients. You're a 12-year-old baseball player who comes in with shoulder pain. I'm going to come in and just already have the diagnosis in my head, which unfortunately is not always a good idea, but more than likely is the case. So what happens in this, and a lot of parents will ask, well, why can't I get an MRI? Once again, back to the MRI, we be careful what we order because of the outcome or the results, number one. Number two, is it going to affect or change our treatment plan? You get an overhead athlete with shoulder pain, you have someone below the age of 18, 16 conservatively, you always get bilateral films so that you can compare that growth plate, and then you can make a slam dunk diagnosis itself. So up here, the right Humerus is on your left and the left shoulder is on your right, and as you can see, the epiphysis itself is slightly widened or greatly widened, leading to certainly a tremendous amount of lateral deltoid pain and a lot of pain with throwing. So then comes the uncomfortable conversation of stopping the early Greg Maddux from throwing for a few weeks or months before he can start throwing again. All right, elbow pain. Another one, little leaguer's elbow, same thing. It is a growth plate abnormality associated with a distal humerus, often medial elbow pain. Sometimes you can see on physical examination an actual difference between the epicondyle, between your the contralateral elbow, pain directly over it. Once again, a slam dunk. But what we always do is get, of course, bilateral films, which we'll see in just a second. Another thing to consider is an osteochondral defect, which is another reason why we get x-rays and a lot of musculoskeletal problems, because you get to start seeing things that you thought, oh gosh, I didn't know that was going to be there. But as you can see, a little bit of the lighter shade in the distal humerus there right at the radial head, a little lesion or a little defect in the cartilage that covers the end of the bone. Usually affects the capitellum, also associated with lateral elbow joint pain. So here are the x-rays in a little leaguer elbow with the humerus and the medial epiphysis or the medial epicondyle. As you can see here, the right, a little bit widened than the left. Once again, it's very soft tissue. So the ligament, parents are gonna be like, oh my God, he needs Tommy John surgery. Well, no, it's just the ligament. It's just the growth plate that is inflamed. It is an inflammatory process. You treat the symptoms. And it is generally not a surgical problem unless it becomes wider, certainly more than 2 centimeters, or there are loose bodies that you see floating around in there. All right, how we rehab it, there's no cookie cutter recipe book, cookbook out there, but what I always tell patients is that we're gonna individualize it to you, but there's always a period of rest. And if you wanna say 4, 4, and 4, that's perfectly fine, and that would be 4 weeks of rest, 4 weeks of a return to throw protocol, 4 weeks of physical therapy, and then a 4 weeks of return to throw protocol. That is not set in stone, and but it gives them an opportunity to say, okay, I might be out for 12 weeks or 3 months, and then if they're back before that, they get a little happy and a little giggly because they get to go back to the showcase over in Orlando in December. Core strengthening, the most important, we tend to forget this. We always, why if my shoulder hurts, why is my core gonna be strong? The biomechanics of the throwing motion, of course, is almost all directly related, but the kinetic chain with the core itself, and that's what supplies a lot of the torque associated with your upper extremity and the very unnatural throwing motion of a baseball player. So core strengthening, I've had patients come back after the follow-up after starting therapy, and they're like, he didn't even touch my shoulder, but it's a really great idea to start on the core itself. Then there's a return to throw program. Of course, there's a return to throw followed by return to mound if you are a pitcher. If you're just an overhead athlete, it's the return to throw. And we have those in our clinics if anybody was ever interested in looking at those. But the most important thing, like Kevin alluded to in almost every musculoskeletal condition, if you don't take away or treat the underlying cause, if there is a disassociation between how they're pitching, the bad biomechanics, they're gonna come back with the same exact thing. If they're throwing something, they're throwing junk before they're supposed to, they're throwing curveball, they're gonna come back with the same exact kind of injury itself. So a lot of times you should suggest a pitching coach, which they usually have one already, which is already pitching them like a Major League Baseball player anyway, but a pitching coach to really stress and reinforce proper mechanics associated with the pitching motion, because a lot of times kids in their small musculature, their youth, they get tired easy when they throw too much, tired a lot more quickly than an adult, and then their mechanics really suffer, and that's when injury starts happening. All right, so hip pain. Once again, our whole theme in this particular talk is we're focusing mainly on the growth plates. So you have somebody who is sprinting, suddenly pulls up, and they had developed pain either anterior or posterior in the hip, and you probably are a growth plate until proven otherwise. So when you have an avulsion injury associated with the growth plate, the anterior inferior iliac spine is the most common, which I thought would actually be the ischial tuberosity associated with a hamstring, but the rectus femoris attaches to the AIIS, and when they have tenderness directly to palpation over that, you just get an AP pelvis and you can compare each side. Once again, when you see an elevation, if they're point tender, diagnosis of very mild. When you see a difference in size, you can diagnose obviously right then. And then if it is certainly separated more than 2 centimeters, sometimes that is often when a surgeon becomes involved. I had a patient last year who came to me for a second opinion because the surgeon said that you needed surgery, and I took a picture. I'm like, yes, you need surgery. You probably would be more beneficial because in this particular case, the ischial tuberosity was pulled off 3 centimeters, and it probably was not going to go back. It was very large. Perthes disease is a preteen, usually oftentimes male, but it's where there's flattening of the femoral head. Usually that surgery doesn't happen until they become symptomatic, which oftentimes is later in life, in their late 20s, early 30s often. But we love saying the word SCFE, slip capital femoral epiphysis, and that the most common presenting or the most common person who presents this way is a pudgy dude. So a little kid who's a little fat starts developing hip pain, or all of a sudden had a pain in the hip itself. You have this high interdifferential, but what is also very common is that it actually presents as knee pain or thigh pain. So don't forget that things are actually related in the human body, and just because they have knee or hip pain doesn't mean that another joint is affected. Don't forget to examine and investigate the hip above, the joint above and below. All right, how do we rehab it? There's a time of protected weight bearing. I put them on crutches if they have a limp. So I usually crutch them until they stop limping. They walk without pain. That's when I have them start rehab with some stretching. And once they have stretching, then you start strengthening. When they have an acute SCFE or when they have SCFE overall, it's often a surgical management. If it's a progressive onset of pain, they can just go and see the orthopedic hip surgeon in the next available. But if it's an acute injury that happened this morning, you'd probably have an emergent type issue with you. All right, knee pain. Knee pain. One of the things that is missing on here is another bane of the sports medicine physician's existence is teenage girl pain, patellofemoral pain syndrome, which is so common. And so it is something that worth talking about off the slide a little bit, in that you present, a lot of girls present with this anterior knee pain, once again, unrelated to any injury, and it doesn't really have any mechanical symptoms associated with it. And what I have found, it's extremely difficult to treat. You'll end up going down this path of a $1 million workup, and everything usually comes back normal. So that then begs the question, what is causing the pain? Well, once again, there's the difference in structural and functional pain. So when she is moving, likely is when she's having the pain, as opposed to a structural abnormality causing it. So in this case, you treat from the floor to the hip. And so oftentimes we'll put somebody in arch supports, which I rarely recommend actual orthotics that are custom made, because those are $400 to $600 out of pocket, but really good over-the-counter arch supports, and then hip abduction and hip strengthening with core strengthening oftentimes relieves knee pain 100% of the time. The two apophyses associated in the knee are the Osgood-Schlatter and the Sinding-Larsen-Johansson, which most of us are all familiar with. All right, once again, rehab is symptomatic for most kind of knee injury, and also the growth plates. Also symptomatic care, ice, heat, topical anti-inflammatory, short-term oral, and go from there. Foot and ankle pain, Sever's disease is the most common. Most people think that when they come in that it certainly is an Achilles tendon issue, when in fact it's just the growth plate where the Achilles tendon is actually inserting. Once again, it is symptomatic relief and then a very aggressive stretching program for the calf musculature itself. Another topic that we don't always talk about, but very common in children, the most common thing associated with low back pain is just soft tissue. And the very thing to stress is don't let them rest. A relative rest is perfectly fine, but don't let them have bed rest. Keep them moving, some different modalities, and go from there. The other thing that parents always ask about too is what if he has a herniated disc? Usually not the case. It's very rare in this age group, but what is more common is the stress fracture of the pars interarticularis, and that is commonly used to pop around different physicians too, because it's very amenable to conservative treatment. All right, we're going to go through the rest of it because it's a long kind of a section, and we're out of time, so we can get you out of here. So